I'd like to invite Aidan Burrell up to the stage. He's an intensivist at the Alfred, and he's going to be talking to us about ECMO-CPR. Aidan, thanks.
Morning, everyone. Thanks, Alex. Thanks for the opportunity to come and talk to you all today. I'm going to talk about ECMO-CPR, and I'll just say from the beginning, this is something that I really enjoy doing and talking about, but it's a very small niche part of this broader concept of in-hospital cardiac arrest. So it's a small niched part of the management of this overall problem. I'm going to take you through some slides about this and some of our experience at the Alfred. I've nothing to declare except that I work in an ECPR centre, so I'm highly biased towards ECMO-CPR. I'll just put that out there at the beginning. And most of the evidence that we talk about tends to be single centre retrospective case series, and there's to date very little randomised evidence to guide our treatment. So I'm just going to briefly go over the outcomes without ECMO, but that's been already really well covered by the previous speakers. What is ECPR? Some of the lessons we learnt from a trial we did, some of the current ECPR data, and then also where is this all headed? So as we've just heard, the excellent ANZ code study for in-hospital cardiac arrest shows that survival to discharge is around 26%. We just heard the long-term outcomes, which was very interesting. And the median resuscitation time for these in-hospital cardiac arrests was 6.5 minutes. So it really is a small number who have prolonged cardiac arrest, which we're talking about in ECMO-CPR. The Victorian registry for out-of-hospital cardiac arrest tends to, the survival is a lot lower. We're looking at sort of 13% in the Victorian registry, and internationally it sort of ranges 8 to 20% as well. So clearly we have a lot of room to improve how we manage these patients. Really just to put ECMO-CPR into context, early defibrillation and bystander CPR, these are really important measures, and this is really the mainstay of treatment of cardiac arrest. When we have a patient that's arrived with ROSC into the hospital, doing things like cooling or at least targeted temperature management, there's really very little benefit between 33 versus 36. We'll rate the results for further trials. Adrenaline doesn't seem to really give much benefit. It may improve the amount of ROSC that people get, but it's at the expense of other neurologically injured patients in the long term. Cardiac arrest centres, also a really good idea, but really hard, solid evidence that shows a real benefit is hard to come by. So when we're talking about interventions, we really lack a lot of interventions that are going to make a big difference once the patient's arrived at hospital. So what is ECMO-CPR and where does that fit in? So ECMO-CPR is rapidly inserting wires and then cannulas into a patient and then hooking them up to a ECMO circuit to provide cardiovascular support during cardiac arrest. It's most commonly thought about where you actually put someone on during the CPR, although technically the definitions used by ELSO and some of the other registries is up to 10 minutes post-ROSC. So there is this period of post-cardiac arrest, the post-cardiac arrest syndrome that was mentioned, where there's quite severe hypertension and heart failure, and that also is a reason to put someone on ECMO if they're unsupportable. The whole aim is to provide organ support, perfusion, increase your diastolic pressure and perfusion of coronary arteries, and to enable to facilitate organ support, but also to enable other interventions such as a PCI or various other interventions that might help the patient. It's really been going off. You've probably read about it or seen it in the media. There's a lot about it on Twitter, if you follow Twitter. And there's a lot of real enthusiasts for ECMO-CPR, disproportionate to how much benefit I think that we'll eventually be able to give, but it is very interesting. So the current guidelines from ILCOR suggest that ECPR should be considered as a rescue therapy for patients where ALS is unsuccessful, or to facilitate specific interventions like PCI. They sort of highlight the lack of evidence, so a lot of this is still not evidence-based, although we're slowly building on the evidence base as we go. So we talked in the previous session about all cardiac arrest patients, and then we can divide that further into in-hospital and out-of-hospital cardiac arrest. And then if we're looking at in-hospital cardiac arrest, ECMO-CPR patients are really a very small niched group within that. So it tends to be younger patients, witnessed arrest, where the no-flow time is less than 5 minutes. So the no-flow time is the time from arrest to time of CPR. It's for patients with a prolonged arrest. So again, the data that was presented earlier, the median time of 6 minutes, we're really looking at the very small niche of refractory cardiac arrest, and usually it's anywhere from 45 minutes up until about 90 minutes would be the longest that most studies quote. The survival in this group that I've just described without ECMO is in the range of 0 to 2%. So this is essentially a population that without an ECMO-CPR program, in most centres people would stop resuscitation, prolonged cardiac arrest over 45 minutes. So just to sort of highlight that. So just last year there was a systematic review and meta-analysis of looking at how does ECMO-CPR perform if you compare it to conventional cardiac pulmonary resuscitation. And if you look at this systematic review, looked at 13 observational studies over the last 10 years, and it showed that ECPR will improve survival with a relative risk of 1.6 with reasonably strong confidence intervals. This was also significant in in-hospital cardiac arrest, but interestingly not in out-of-hospital cardiac arrest. And the question is, why is ECMO-CPR not working in out-of-hospital cardiac arrest? There's a few different potential reasons. I guess we can look at comparing some of the ideas of why ECMO-CPR would work in the first place. So in hospital cardiac arrest, the patients are often witnessed, as we just heard, and the deterioration is recognised, so people can prepare faster. About a third occur in intubated patients, and a greater number occur in the ICU or in a high visibility area. So again, the recognition is a lot faster. The main reason, I think, is that the low flow time is able to be a lot shorter in hospital cardiac arrest. On the flip side, though, the advantages, you could argue, why out-of-hospital cardiac arrest patients may do better is that they tend to have a higher rate of shockable rhythm. The cardiac cause is more common in this population, and they tend to be younger patients as well. So all of this background really led to a study we performed at the Alfred Hospital, published in 2015, called the CHEER trial. And this was a prospective observational study looking at implementing a ECPR program into our hospital at the Alfred. And the intervention was out-of-hospital patients being put on the autopulse device and CPR to the emergency department. In-hospital patients undergoing CPR and plus or minus the autopulse, and either being cannulated in the wards or being moved into the ICU. Hypothermia with a 2-litre bolus of cold saline, cannulation, as I mentioned, and then emergency or very early reperfusion. The inclusion criteria we used then was cardiac arrest that was presumed cardiac origin, a VF, initial rhythm, and a CPR time of 30 minutes or more. We've subsequently changed that criteria for what we do in practice. I'll come on to that in a second. The population, we had 26 patients who were enrolled in the original study. 11 were out of hospital cardiac arrest and 15 were in hospital cardiac arrest. The low flow time, that's the time from arrest to the time of establishing ECMO, was a median time of 56 minutes, and the ED arrival time to ECMO flow was 20 minutes on average. The outcomes we got in this group was 54% weaned from ECMO, and then everyone who weaned off ECMO was able to be discharged, and the neurological final status in all those patients were CPC1. So very surprising, this very high survival rate. It hasn't really been matched around the world and ever since, and I think it probably was an anomaly to have such high survival rate. But I guess some of the key take-homes, I think that's my next slide. No, not my next slide. Was that these patients who otherwise would be normally, resuscitation would be stopped, that with a resuscitation program that quite a large number of people can go on to survive. So it generated a lot of interest. This man was dead. This is quite provocative, but resuscitating patients after a median time of 54 minutes and then having a 54% survival was a big shock, and continued on. This is what it looks like in practice. We have a trolley set up in the ICU, and we push it down to the emergency department, and we have some boxes that have been set up to help us do the same process each time and facilitate things. We have some roll cards where we have both a resuscitation team managing the cardiac arrest, and we have an ECMO team cannulating and initiating the circuit and the console and things. We do a lot of simulation training with the emergency department, with our nurses, and also the ECMO team. So there's a lot of simulation. It's actually brought all of the different departments together, and it's been a really good process to go through. So what were the key take-homes from the CHEER trial? It takes a lot of resources to run an ECMO-CPR program. We now have 24/7 consultant cover and in-house night shift. There's a huge bank of ECLS-trained nurses who really go above and beyond the standard care and have a very good detailed understanding of how to run the ECMO circuit, how to troubleshoot problems, and all of that takes a huge amount of training and education to do. As I mentioned, we do simulations. We run a cannulation and ECMO course twice a year. And I guess the other thing is, the significant burden. A lot of these patients do die, and the mortality rate is taxing, takes a lot of resources, and there's a high risk of burnout in working with these patients. And finally, the lesson was that getting patients to hospital faster is very challenging. The paramedics do an excellent job at resuscitating patients, packing them, bringing them to the hospital, but getting them here faster is very challenging, and it's work that we are going to continue to do to try and improve things. Look, just a couple of studies just to kind of emphasise some of the points I've made. So this study was an observational study from Korea that looked at 52 ECPR patients and compared it to 444 conventional CPR patients. And as I mentioned, the ECPR patients tended to be younger, have less comorbidities, and a high rate of shockable rhythm. This is due to the fact that we're talking about a very small niche group of patients that's highly selected. But interestingly, their CPR time, as I've mentioned, it tends to be a lot longer, so this is the refractory cardiac arrest population. The survival in the group with conventional CPR, who had ongoing CPR beyond 21 minutes, was 2%. So this is a group, the ECPR population is a group that the survival is approaching zero. With the ECPR program that they set up, survival at 24 hours, 3 months, and at 3 months was 18 to 20% overall. So we're looking at an absolute risk improvement really of around 18 to 20%. So it really is quite a powerful intervention. I just want to highlight the influence of low flow time. So this is the time from arrest to going on ECMO. So unlike in conventional CPR where the importance is still to get ROSC as fast as possible, but 1 minute or 2 minutes probably is not going to make much difference. In ECPR, really getting that low flow time down as low as possible really is the key. So in this study, of 133 ECPR patients, 74 were in hospital cardiac arrest and 59 were out of hospital cardiac arrest. All of them got ECPR, and it showed that if you can get your low flow time down below 49 minutes, the survivor is much more likely to have a short low flow time than in the non-survivors. And survival is better in hospital cardiac arrest versus out of hospital cardiac arrest. So I think that the point is that in hospital cardiac arrest, the survival tends to be better in ECPR rather than out of hospital cardiac arrest. And I think the key thing is just the timing. We can put people on faster in hospital cardiac arrest. So that really needs to be the emphasis, is early recognition and then a rapid response to get people on to ECMO. Just to update the numbers from the CHEER trial, we average between about 15 and 25 ECPRs per year, and that's been relatively stable, hasn't really changed. The majority are in hospital rather than out of hospital patients. And if you look there, you can see that the in-hospital numbers are 33 total compared to, the total number is 78 versus 58 in numbers, and the survival to discharge is 42% in hospital and 20% in out-of-hospital cardiac arrest. And you can see the mean CPR duration also is half, basically, in hospital versus out-of-hospital cardiac arrest. So really the essential take-home for ECPR is that you have to get people on very quickly, and that will reflect your survival to discharge. Final comment about how we can improve the service. This study showed that not only is it your total duration of CPR and low flow time, it's also the time from when you start to cannulate to when you finish to cannulate. So a lot of training needs to happen to optimize your call-out systems, your cannulation efficiency, getting people on a circuit. All of these things are things that we can improve and simulate, and I think we're going to be able to improve outcomes further. So where are we headed with all of this? So I think defining even better which are the key patient populations that can benefit from this, from ECPR, and further studies are coming to help define the role. We have a Victorian ECMO service which has been developed, and also strategies to reduce low flow time. So there's currently 5 randomised controlled trials around the world looking at ECPR and looking at both a combination of early referral to hospitals for patients that arrest out of hospital, early referral and scoop and run to hospitals versus staying and continuing resuscitation. That's one sort of methodology. Another methodology is to randomise different centres. So some centres will have ECPR, other centres won't. This will provide a lot of good evidence in the long run. And then there's also multiple observational studies, as I said, looking at trying to target which patients are going to benefit from this and which patients do we not want to put on ECMO. I'm not sure if anyone in the room has heard about the Victorian ECMO service. This is a initiative of Safer Care Victoria looking locally at how we accredit and train centres to provide ECMO-CPR, looking at refining the inclusion-exclusion criteria, and also how we coordinate this at a statewide level. I think this is really important work that will ultimately define how we provide ECMO-CPR. It's not something that The traditional model of ECMO we've had in the state has been retrieval based, where a retrieval team goes out and cannulates people. That works for VV ECMO and it works for VA ECMO. If you have enough time to send a retrieval team out, you can bring all that expertise there. That clearly doesn't work in ECPR, where someone's in cardiac arrest. So I think it's going to be training up local hospitals to initiate ECMO and then to transport them to an ECMO centre for ongoing care. Finally, how do we get that low flow time down further? And the real exciting area in this space is, rather than bringing the patients in out-of-hospital cardiac arrest to the ED department, why not take the ECMO team out to the patient and initiate ECMO actually in the field? There's a group in Paris who've published a lot on this, and they've shown that they can reduce their time to their low flow time right down. I think moving forwards, this is going to be something that will, I suspect in the next 10 years, will become more routine. We're just about to start a pilot study of 20 case ECPR patients to establish the feasibility and safety of this program of pre-hospital ECPR. And we'll look forward to that coming out. So just to summarise, survival in cardiac arrest that's refractory without ECMO is very poor, particularly after about 20 minutes. ECPR improves that survival, but it is challenging to deliver. In hospital, ECMO is associated with better outcomes than out-of-hospital ECMO, ECPR, and this is probably due to the shorter low flow time. And so moving forward, we need the results of these trials, further guidelines, and then also moving towards pre-hospital ECMO, and we'll see if all of this improves the outcomes further. Thank you very much.